welcome everybody. Hello and welcome to this NOAHE rounds session. It's, I think, our fourth series, and this is our fifth session in that series. So I'd like everybody to join me in welcoming our presenter today, Dr. Ian Cromwell. Dr. Cromwell is currently working at CADTH, and in his current role, he oversees evidence appraisal and synthesis projects for drugs and other health technologies to inform Canadian healthcare decision-making. So during today's seminar, Dr. Cromwell is going to be talking about whole disease modeling for health technology management and the need for open source approaches. So really interesting topic. Look forward to it. So just a bit of background, whole disease models are designed to address broader decision environment around a given technology adoption question. So how do upstream and downstream policy changes impact the cost effectiveness of an intervention of interest? As HTA agencies increasingly consider a shift towards the management of technologies, that is considering their implications of their full life cycle beyond the adoption decision, these whole disease models have a clear application, and that's definitely something at IHE that we've been looking at in recent years as well. So the complexity of these models is especially obvious in the presence of rapidly evolving changes in the structure of the healthcare system as well. And the availability of new technologies means that these models might be obsolete by the time they can be built. So today, Dr. Cromwell is going to describe the design, construction, and use of a whole disease model for the purpose of for this purpose in the context of oral cancer and the necessary role that collaboration through open source decision modeling approaches will play if the full potential of this approach is to be realized. Before we begin, just a couple of housekeeping items. Throughout the webinar, participants will remain muted, so you will not be able to, but you can speak, but you won't be heard. If you do have a question, please submit any questions through the question functionality on the GoToWebinar software. That will flag it up to myself and to Ian, and we'll be able to answer them. We'll have a question and answer period at the end of the presentation. Please note we'll be holding all questions until the end to allow Dr. Cromwell to get through his presentation. So all that said, I will hand over to Dr. Cromwell. Thank you for joining us, Dr. Cromwell, and away you go.
Thanks so much, and thanks everyone for being here. It's I'm excited to be here. I'm flattered to be here. I also want to take a moment just to say thank you to my opening acts, Lady Gaga and President Biden. It means a lot to have you warm up the crowd for me. So as mentioned, I'm going to be talking today about whole disease models, health technology management, and open source approaches. Before I get started, I just want to flag that I have no personal or professional conflicts of interest that are relevant to this presentation, and that all of the opinions expressed reflect my own thinking and not that of my employer or former employers. I'd also like to start off by acknowledging that the bulk of this work, the near entirety of this work, happened while I was an employee at BC Cancer, and as a member of the Canadian Centre for Applied Research in Cancer Control. Some of this work was also funded by Genome British Columbia. The work that I'm presenting today, the research work, came out of my PhD thesis, and so this was obviously a collaborative work with my committee, Drs. Bansbach, Peacock, Poe, Worker, and Black. Much of the clinical components of the research work that I'm presenting today were verified and conducted in conjunction with a clinical advisory panel, a variety of clinical experts who sort of helped me navigate the complexities of the clinical environment. And there were also a number of other people I need to thank for their assistance with how to do a lot of the coding and architecture that went into this, the data collection and analysis, and some of the biostatistical work as well. I also want to take a moment to acknowledge that a lot of this work, a lot of the data that informs this work came from a retrospective cohort of patients. This was a group of about 900 oral cancer people who had been treated for oral cancer in British Columbia. And so this work literally reflects their lived and dying experiences. And I want to just start off by expressing my gratitude to them and my appreciation. So what I'm going to be talking about today is sort of where I am on a journey that started maybe 6 or 7 years ago, when I was working at BC Cancer, and I was tasked with conducting a cost effectiveness analysis of a method of providing risk stratified management for oral pre-malignancies. So like many cancers, oral cancers start with lesions, like visibly detectable growths, that are not necessarily cancer yet. And a lot of those will never develop into cancer, but some of them will. And the current standard of practice is to just have people come in for regular observation and look for changes. But there is a property of these precancerous these precancerous pre-lesions. Sometimes they're called OPL, sometimes they're called low-grade lesions. But there is this molecular property called loss of heterozygosity, and they had conducted a clinical trial at BC Cancer and found that there was a way to use a molecular assay to risk stratify people. So if you have, you've got a low risk, got a medium risk, you've got a higher risk lesion, we can do different management. And so I built this model, the idea being that people who have low risk disease can come in for reevaluation less frequently. Because we have good statistical evidence to suggest that they won't actually develop into cancer ever. People with intermediate risk can come in on a sort of a semi-attenuated schedule, and then people who have high-risk lesions will be they'll be surgically resected immediately, with the idea that it will never develop and not have a chance to develop into cancer, and so we'll see better local control. And so we built this model and we contrasted it against standard of practice, where we don't know what someone's risk score is, and we just keep seeing them on a regular basis until they develop, or until it looks like they're going to develop cancer. What we found through this analysis is that the molecular assay dominates standard care. So we saw lower rates of cancer transformation, we saw a corresponding increase in qualities, and because people didn't have to come in as often, we saw a reduction in cost. And so we, at the other side of this work, the clinical team and I were sort of just kicking around ideas and talking about different strategies for oral cancer control. And the impression that I got from these discussions is that it's sort of a fertile policy landscape. There are a lot of different things that are affecting the way in which we might control and reduce the rate and severity of oral cancer. So HPV vaccination, which was ramping up at the time in BC, means that we're likely to see an effect for oral cancers as well as cervical cancers, as well as other cancers. And so that's going to have an impact on oral cancer control. We typically, the way that these pre-malignancies and oral cancers generally get detected is through partnership with community dentists, and they notice something odd and they refer you for more intense observation. And so if we had been discussing, like, how does this stack up to greater adherence to screening protocols and screening guidelines? What if we had better tools for screening that were more precise, so we would get a more appropriate rate of referrals? I don't know if any of you have been to the dentist and they shine that blue light in your mouth. That's the tool's called a Bell scope, and it uses this autofluorescent property of precancerous and cancerous epithelial cells that they glow in the dark differently than healthy tissue. And so that's what an oral cancer screening can look like. But it also could, the group there was looking at using that in the actual surgical theater to draw surgical margins around pre-malignancies or tumors to reduce the rate of local regional recurrence. And then there's always the possibility that some improvement in later stage disease will come along and have a dramatic effect on the rate of refractory or terminal survival. And so the issue was not which one of these do we look at. The issue for us is that it was really likely that they were all going to happen, that all of these things would be making their way into practice within the next few years. And if we wanted to conduct economic evaluation for any of them, we would have to consider the cumulative impact of all of them, because that is the direction in which the decision environment was moving. And we had a very relevant question, which is, we've done this cost effectiveness work for this molecular assay, but what happens when we add all this other stuff? Is it still going to be useful? Is there a specific combination of these policies that's going to give us better value for money than others? And so there was this, you know, I'll give an illustration. So this is sort of the general pathway for most cancers, but oral cancer for sure, that starts with people being in, you know, undetected pre-disease, and they don't necessarily know that they have any kind of abnormalities in their epithelial. If a preclinical lesion is detected, they will go for preclinical management. If they are detected, the cancer is detected at an early stage, there's a protocol of management that's usually surgery, maybe radiotherapy. For late stage, it's a little more involved. If you are refractory to treatment, or you have, you know, you experience a recurrence, there's a different way of managing that. And then finally, people who have terminal illness. And this is like kind of a standard pathway for oncology generally. So let's imagine that we have a decision that we have to make, a policy decision, some technology that we want to think about adopting. Let's call it D1. And if we wanted to model the cost effectiveness of D1, and it occurs, it's a treatment for, you know, people with late stage disease, stage 3 and 4 disease. We could build a model that includes all of these sort of downstream effects and health states. So that it would include people who have recurrence or who don't respond to treatment, as well as people who are terminally ill. And then we can take that model and we can run it, and we can get a change in cost and change of effectiveness, and get our cost effectiveness analysis that way. And then if we had, you know, a different policy, let's call it D2, and D2 is, you know, in a preclinical stage, we would then have to build a model that includes all of the things that are downstream from that point. And we would get a different estimate of cost and a different estimate of effectiveness, because there are different processes involved. And as I described, what we were talking about, the reality that we were discussing, is that there are going to be multiple decisions happening at the same time. And they are not independent from each other, because if you have some way of reducing the amount of asymptomatic disease in the population broadly, that's going to affect the frequency with which you detect preclinical lesions. There'll just be fewer of them, which means that you're going to have the sensitivity and specificity of testing is going to be affected as a result. A number of people who you detect preclinically versus at the point where they have full-blown cancer will change as a result of changes in the preclinical stage. And that will go on to affect the incidence of refractory and recurrent disease, because if you treat people earlier in the process, they are less likely to develop recurrence in the first place. And so the impact of a recurrence or a refractory management strategy is going to be affected. And so we could consider these various combinations, and each one of them is going to be associated with a different measure of incremental cost and a different measure of incremental effectiveness. And then there's the question of optimization. Of what if we don't like one of these policies? What if we think that the evidence is not sufficiently strong, or that it's not cost effective on its own, or whatever the reason we don't like, let's say D3. We are then in a world where we have a different combination of policies with its own costs and effectiveness. So this is where we were, and we're trying to, puzzling our way through it. And through kind of a staggering coincidence, I happened to be part of a health economics journal club that was a regular monthly thing in Vancouver. And as we were puzzling through this problem, someone brought this paper forward for discussion among the group. And this is a paper by Paul Tappenden and colleagues, where he lays out the methodological framework for conducting whole disease models. And so those of you, if you haven't heard of a whole disease model, you can pretty much figure out what it is from the name. The idea is to build one model that reflects all of the likely events, all of the likely processes that happen along a patient's trajectory, all the way from preclinical disease when there's nothing going on, all the way down to terminal disease. And the key is that it's not built for a specific decision. It's not built so that you can evaluate technology. The idea is that you can move the decision node around within the model to look at a bunch of different decisions, either alone or in combination. And so you can then measure or sort of estimate the impact that upstream or downstream policy changes from your policy of interest might have on the costs and effectiveness of that policy. And this is a response to the idea what Tappenden calls piecewise approaches, where you build a model that is fit for purpose, that it evaluates just the processes that are immediately relevant to your decision that you are trying to make. And the argument is that those can't reflect things outside of the policy of interest, but those may nevertheless remain relevant. And so my thesis work started, at least, as an attempt to construct a whole disease model of oral cancer. So it is a next event simulation discrete event model. It uses individual sampling, so we don't see interaction between entities. Those are the simulated people in the model. They don't wait for things, they don't queue, they don't have any interaction with each other at all. Entities in the model, they may or may not have a pre-malignancy, like an undetected pre-malignancy. If they have access to a dentist, they go through a screening process. If they don't, they might be detected symptomatically. If they are detected, it's managed at a specialized clinic. If they develop a cancer, that's managed according to the stage of detection. People will undergo clinical follow-up following treatment. They may have a recurrence, and they may develop terminal illness. And so all of these points are within the one model. A lot of the parameters and the structure about the natural history and screening parts of it were taken from a pre-existing model that was in the literature by Spate and colleagues. And as I mentioned before, we had this retrospective cohort of oral cancer patients, and so I was able to link their records to records held by the Cancer Agency and by the province of British Columbia to get a fairly comprehensive look at resource utilization, and then to use a unit costing approach to derive cost. And also we got survival and time to progression and time to second recurrence and so on from that same data set. And then the whole thing was evaluated against cancer registry data to make sure that the distribution of cases of cancers matched what we see in the population. This is a brief overview of the structure. It's underpinned by this natural history process where people who have a pre-malignancy, it may develop to a more severe form of disease. At any point, it might be detected symptomatically. That you might just have pain or bleeding or whatever in the mouth that is then evaluated and diagnosed as cancer. There is a screening component for people with who are precancerous. As I mentioned, if they have access to a dentist, they go through a screening process where they might be referred to oral specialists. And then if cancer develops, they will go on to receive specialized care. If they don't have a dentist, then it might be detected through symptoms. If they have a pre-malignancy, they're managed at that specialized clinic that I mentioned before. Cancer is, as I mentioned, treated based on stage at detection. There's also a similar process for people who have recurring disease, and then there is a follow-up procedure for people who are in remission. As I said, it's a next event approach to modeling. So what we do is that each event is scheduled at, and then the next event is the time to the next thing occurring is sampled from an underlying probability distribution. And so entities will go from one event to another event to another event on this pre-programmed, or on this sort of next event programmed path. The events occur in simulated real time, and at each event, at each point, the entity will carry with it a record of the events that have happened, any changes to their personal characteristics, resources that they've used, utility that they experience as they go. And each entity is sampled independently, created independently, so that they start with their own set of characteristics. And what that allows us to do is to simulate a cohort of people who have gone through the model under our experimental condition with our new technology, or a comparator condition with our sort of standard of care status quo approach, and then we can use that. We can add up all the costs and consider all of the survival and quality adjusted survival to calculate incremental cost effectiveness. And what's interesting about these models, and I'm going to come back to this a bit later, is that because we're keeping a record of all of the events, we are not restricted to just looking at survival. We can look at any outcome that we find relevant. So I want to turn now to the topic of health technology management. Health technology management is sort of the you could describe it maybe as the next step beyond health technology assessment. The criticism, the critique of HTA is that it is predominantly focused on evaluating adoption of something new, adding something to what currently exists. And the HTM approach is to consider not just when you add something, but under what circumstances might you take it away or modify it. You think of the full life cycle for a technology and for a technology decision. We would think like how might some new thing that we're bringing in displace something that we're currently using, or will it change the cost effectiveness of something that we've already approved? And so it allows us to encourages us to move away from single decision adoption, and move away from, is this new thing cost effective compared to the old thing? But how does this new thing change the cost effectiveness relationship of other priorities, other technologies, other decisions that we've made? This is a slide that I just stole from Craig Mitten. He presented it at the 2018 CADTH symposium. But this is, if we think of, we consider the policy making cycle, that we're always looking to make new decisions. And HTA is here, and HTA gives us information about what happens when we add new technologies to our current roster. And then the opportunity for HTM here is to consider, okay, now that if we make this decision, where are areas where we can make other policy changes that would reduce our budgetary output, such that we can create space for new areas of investment. And the 2018 strategic plan from CADTH says, like, we are going to do this. The challenge, of course, is that it is a very good goal, but the methods of actually putting it into practice are still not quite as solid and pinned down as they are for HTA. And so what my project ended up becoming, we were having this discussion with my thesis committee, and talking about, whole disease models are specifically designed to consider a scenario where you've got multiple decisions happening at the same time. And as a direct result of that, we can think about, well, if we have a decision that comes in, how is that going to change the relationship of costs and effectiveness for another decision that may already be in there? Because we're already thinking about multiple simultaneous adoption. Does the cost effectiveness of X, whatever technology we're interested in, change when we start adding other things? And so my thesis ended up being a case study of using whole disease models to conduct health technology management in the form of the molecular assay that I presented earlier. So the research question was, what is the cost effectiveness of risk stratified pre-malignancy management using this assay in the presence of other potential cancer control policies? So it's the same cost utility question. It's assay informed care, risk stratified management versus the status quo without the assay, but in the presence of other things that might be going on. And so we chose 5 different potential policy scenarios. The first is the idea of reducing the risk factors that are in the population through an alcohol and tobacco cessation program. So this is going to have a population level effect that will also have a potential impact on the prevalence of pre-malignancy in the population. We looked at improving screening and having more precise screening methods. We looked at better surgical procedure using the that fluorescent guided approach in the surgical theater for early stage diseases. We considered a hypothetical, whiz bang, super cool, game changer drug that we, periodically are asked to believe in. Something that would reduce the mortality in late stage disease, but that has a very high cost, like a pretty typical HTA kind of scenario. And then finally, the impact of HPV vaccination, and we hypothesized that there were 3 potential mechanisms of action. One is that less HPV in the population means fewer premalignancies in the first place. Second is that HPV negative premalignancies may progress more slowly into cancer. And finally, that HPV negative cancers are less likely to have recurrence. There's some evidence for all of these in the literature. So costs, transition probabilities, and utilities were derived from literature sources. Excuse me. And I want to stress here that this was an illustrative exercise. And so I don't want anyone to get too bogged down in the specific numbers. I don't think that there is sufficient rigor in my approach to say definitively, like, this is what would happen. But it was really to illustrate the effect that other policy adoptions could have, or like just to show that the upstream and downstream policy implementation does matter. We simulated populations of 1.2 million entities to ensure that we had a sufficient number of late-stage cancers in the analyzed population, and we calculated net monetary benefit of using the assay to do risk stratified management under 32 different combinations of those 5 policies. And so this is what the result was. And you can see here in red, this is our baseline measure of, in the absence of any other controlling policy, this is the cost effectiveness, or the net monetary benefit rather, of the use of the assay. And as you can see, both these upstream and downstream programs changed the cost effectiveness of an additional technology. There was a few where it dropped below the y-axis, or below the x-axis as well. I'm not showing those, but they are there. But really, the take home here is that policies that lie outside of the decision of interest can have an impact on the cost effectiveness of that policy. The original model that we built, the Markov model that I built for the original question, would not have been able to capture most of the policy options that were in this scenario analysis, because they outside all of the sort of most relevant processes for how we constructed that original model. And I think what this shows is that whole disease models are perfectly ideally suited to asking these health technology management questions. That we can look at multiple policy adoptions, we can add things, we can take things away, we can look at different combinations and get some helpful results. So I'm writing all of this up, and I'm thinking about the sort of basic claim of the whole disease modeling framework, which is that piecewise approaches, the sort of current standard where we build a model for purpose, the critique is those can't possibly reflect all of the relevant decision pathways. And I started thinking about my own work, and I was thinking, like, does my model, complicated and data heavy as it is, does it live up to that standard? Does it reflect the impact of all of the relevant decision pathways? Well, of course not. I mean, there's a practicality point of view where you have to start simplifying things. Simplification may lead to oversimplification, and it's very difficult to know when that's occurring. And that is not just true of my work. That's true of anyone who is going to build a whole disease model. Is it even possible to reflect all of the relevant decision pathways? The other thing that was really bothering me is the changes between jurisdictions has a big impact on when we talk about, like, all the relevant model processes. So if you get oral cancer in Ontario, or you get oral cancer in British Columbia, your management is going to be pretty much the same. There's not a lot of change. But if you have a pre-malignancy, it's a completely different world. the way in which referrals and the patterns of specialists who see pre-cancers at different stages is different in Ontario than it is in British Columbia. And like, that's just one jurisdiction. As soon as you move to a different country, again, the game changes every time you move from the local context. There's huge amounts of data that are needed to power this. We needed to have input from a broad variety of experts across multiple medical specializations. The creation of the model was, I mean, this took me years to build. Calibration was its own set of problems, and there are, like, we used a pretty bare bones way of doing calibration. There are like indicated best practices for model calibration that are even more labor intensive. And so, like, it's just not practical. It's just not practical. Try to create a brand new whole disease model for every disease, for every jurisdiction in the world. It just can't be done. But if we want to do health technology management and we want to use whole disease models, like, what's our alternative? The other thing is that just changes over time will affect the applicability of your whole disease model. So, like, this whole thing was about, you know, people being treated for managed for pre-malignancy at a specialized clinic. By the time I was done, we didn't use a specialized clinic anymore. So, like, by the time that my research was ready to come out, the model was already obsolete. And we're talking about a world in which technologies are changing so rapidly. New things are being introduced all the time. And so we need to have like a whole disease model, but it has to be agile. It has to be readily adaptable in order to reflect and to remain relevant. Otherwise, you have to just start from the beginning every time. And by the time you finish, it's too late. And so there is a real question about, like, can a whole disease model actually exist? Can we build something that's actually going to be relevant for purpose in the face of all this rapid change? And where I landed on this, where I'm at currently, is that open source approaches offer a potential solution to this problem of data need, this problem of complexity, this problem of agility. For those of you who may not know what open source is, it's not a company, it's not a product. It's a set of guidelines, it's a sort of set of principles in the software design world. The idea is that the design of your software, whether that's a model or something else, should be publicly accessible. Anyone who wants to see the code should be able to access it, have a copy, make a change, work. And the idea here is not to give away the store for free, but rather to emphasize transparency and then foster collaboration so that different people can take a piece of source code and they can innovate on it and they can work together with the originator to build and improve and to maintain important and useful pieces of software. The whole disease model that I built was built in Python. And I chose Python because it's free and because it's fast. And it's a relatively simple language to program in. Like, if you're comfortable writing in R, Python's not that much of a stretch. There are obviously differences, but it migrates to web really well. And I had this vision in my head of the model just being a website that anyone could log onto and use. And what the way that I built the model is that each process, each component of it is independent, and so they can interact with each other. But what you can do is you can take out a piece, reprogram it, and then just plug it back in, and the rest of the model will continue to work. So all of my scenario analyses that I did for the the health technology management scenario analysis, all I did was I took the relevant function within the sort of broader model. I reprogrammed it so that it met my new scenario, plugged it back in, and reran it. And I was able to, it took a little while, but after a while, what I was able to do is set it up so that I could just hit go, and about 10 to 15 hours later, all of those 32 analyses with 2.4 million simulated entities for each combination were just going on their own, and it's just pulling the model structure and the pieces it needs in at the time that it needs it. And it does all that, and it fits in an email. It's less than 2 megabytes. That includes all the data that underpins it. And so this is, I think, like, I was influenced by and trying to emulate as best I could these sort of open source principles where the design, the code itself would be available, and that it would be transparent, and that people who know how to code better than I do could come in afterwards and make their own changes, or people who are interested in replicating it in a different jurisdiction could come along and do the same. We are, like, our discipline and health technology assessment and health technology appraisals, including management, are up against a burgeoning new world in which precision medicine, genomic technologies are they are finally arriving. They are here, and that means that HTA agencies like CADTH or NICE or PBAC have a huge set of tasks ahead of them. Each one of those submissions is going to have not only the actual the disease piece, but all of the other pieces around testing and management and complementary diagnostics and so on and so forth. So the task complexity is going way up, and we are not going to be able to convince drug manufacturers, device manufacturers, to start cranking out whole disease models for a single technology. It's just not going to happen. But how can we responsibly reflect the impact of simultaneous technology adoption without those kinds of models? There is already a move that is happening within health economics, a sort of a shift towards collaboration and towards shared responsibility for model building and verification. There's the decision analysis in R for technologies in health group, the DARTH group, who are starting to demystify a lot of the processes around R to make it more accessible for health economists to do decision analysis. There's a special interest group at ISPOR that is looking specifically at these kinds of open source and transparent and shareable model approaches. This same group, the NOAHE group, would have heard from Dr. Stephanie Harvard a few months ago talking about the Peer Models Network, which is a platform specifically set up to do this kind of sharing and collaboration and mutual co-working. And then there's just this secular move that's happening as people are moving towards R, and it is becoming the sort of default, or one of the defaults, let's say, for how we do biostatistical analysis in health economics. And then there's this other piece that I think is actually important, which is there is a real and crucial, and I think incredibly helpful role for patients and members of the public to play. So like health economics, we use cost utility analysis as the reference case, and I think that's totally appropriate. But there is a fair question about whether a QALY actually captures all of the things that patients or the public find important in a given disease. There may be other symptomatic changes, there may be other things. So like, for example, I did a qualitative component to this work where I was interviewing people as they left a clinical trial for pre-malignant management. And one person relayed to me that they didn't have pain, they didn't have mobility issues, that, it was a minor procedure from their perspective, but they lost their ability to taste. And that meant for that person a complete collapse of their social life, because they would invite friends over to have food, and they were a cook, and it was part of their connection to their heritage. And now that was off the table, couldn't be done. That wouldn't be reflected in the EQ5D. It would barely be reflected in oral cancer specific quality of life tools. But because we're doing entity-based modeling in whole disease models, we can track any kind of outcome that we want, which means that when we consider how we construct our cost effectiveness results, in addition to QALYs, alongside QALYs, we can also include any other input or output that might be relevant. And that, I think, it presents a real opportunity for patients and for members of the public to have constructive and crucial input into what are we measuring, what data needs to go into this, and what data needs to come out of it. So just to wrap up here, there's a question, so like, how do we get to how do we do HTM in open source with whole disease models? Like, what do we need to do? And I I hope that I'm not the only person whose answer to this you're listening to. I've done this once, and it's still full of bugs that I'm trying to figure out. But the way that I see this needing to progress is that there needs to be some kind of consensus about what diseases are most amenable to a whole disease modeling approach. And luckily, helpfully, Tappington's work spells out a specific conditions that should be met in order to justify doing the work of building a whole disease model. And so one of those is when we have a number of anticipated policy changes that are happening across multiple parts of the decision environment. I think from there, HTA agencies within and around the world will need to start pooling expertise and pooling resources and working together to make it possible for these models to run in a useful and evidence-informed way. I think there needs to be some move towards a set of standards, and so that people are, if we are going to do open source coding, that we're all sort of operating from the same playbook. And then I think there needs to be like interdisciplinary training programs. So I think it's very common for health economists to work alongside biostatisticians. I think added to that, there needs to be incorporation of software engineers and computer scientists. That will become just part of how we operate, because there are always going to be better, smarter, and more appropriate ways to build software. So my closing argument to you here, before I guzzle this glass of water, because my mouth is incredibly dry. I've been talking nonstop for 40 minutes. I feel like an auctioneer. Health technology management, to do properly, requires us to consider the broader decision environment, not just a single decision, but the impact of multiple decisions, either adding or taking away from the current roster of technologies. Whole disease models are well suited, very, very well suited to do this kind of work, because they are explicitly about multiple technology adoption. In order for them to be relevant and for them to be useful, they have to be agile and they have to be jurisdiction non-specific, which is going to require collaboration and I think open source methods and open source thinking gets us most of the way there. It helps us reduce the complexity and resource burden that's associated with creating these things in the first place. And I think in order to do that, health technology assessment agencies around the world should be looking at fostering interdisciplinary and international collaborations, so that we can actually bring this technology and this approach to its full potential, and then we can reap the benefits of doing that. I have I thought I would be a lot farther along, but pandemic. My plan is to talk more about this. This is sort of a conversation that I'm interested in. It's ongoing, and I'm interested in sort of staking out my part of it. And so my plan is to be writing a lot of this stuff up, including sharing code and my approach at healthyuncertainty.github.io. You can often catch spare thoughts leaking out of my head at healthyuncert on Twitter. And if any of this work seems interesting to you, if you have any thoughts, or if this is something that you think that you have a different perspective on, I'd really love to hear from you. Please email me, ian.cromwell@cadth.ca. And with that, I just want to say thank you so much for having me. It's been a real pleasure, and I'm looking forward to your questions.
So thanks very much for that, Ian. Does anybody have any questions that they want to put in the question box on the GoTo app or website? And I will try and find them here. I can see the only question so far is, would you like questions in writing? Yes, please. I'm trying to see the question box here. Okay. Nicole, are you able to see the questions? I can only see one line at a time, so I'm having some trouble. If you've got a better view of it. Here we go. No, I figured it out. Sorry, Nicole. So the first one I can see, you say that you've developed an open source model. Have you been successful in getting someone outside of your committee to commit any changes to your code? And what strategies would you use to recruit such activity? So
So
yeah.
that's a really helpful and valuable and important question. The quick answer is no. What happened was that my plans to make this this work public kind of got squashed by COVID. And so the code, like the base code that exists in my thesis is available on my GitHub. It can be, the repository is there, it is public. I have not seen anyone else take it up, but this is also the first time that I've talked about it publicly since I defended my thesis. So I'm not surprised that no one's taken me up on the offer that I haven't made yet. I am hoping that that is among the next steps. The big challenge for me, one of my biggest sort of sources of insecurity on this is that I'm self-taught on a lot of this stuff. I didn't use Python before I started doing this work, so there are going to be a lot of like software engineers and people who are more practiced who will look at my code and sort of shake their head sadly. And so I'm hoping by publicizing it sort of piece by piece and walking through my thought process, that I'll be able to engage folks and sort of learn collaboratively in that way. That's sort of the next step of this work, I hope.
Okay, thank you. I've finally got better control of the question thing, so I will now be able to answer. That was from Daniel Wagner, so thank you, Daniel. The next one I've got is from Andre Lopez. It says, great presentation. I already spent some time and effort learning Python, but it looks like R is the way to go. Should I start from scratch and learn R? I'm not sure that you can answer that entirely, Ian, but
I think probably. I think you're far more likely, at least within the health economics discipline, to encounter fellow R users than fellow Python users. There are things that I think this might be some cost fallacy talking a little bit, but I think there are some things that Python does better in the world of discrete event simulation than R. However, I do know people who program discrete event models in R. I don't know how they do it, but they do it. So it's possible. And I would say that just for a comparability and being able to talk to other people in the discipline, I think learning R is a good idea. I actually have a guide, a how-to guide for people starting off doing health economics in R, which is available now at my website. So that if you're looking at a place to get started, that might be a spot to go. I do know, however, that there is an active work being done to bridge the gap between R and Python. I think RStudio now runs Python scripts, for example. So all is not lost.
Great, thanks. So the next one's from Deborah Marshall. Thank you, Ian, great presentation and agree. Can you speak to what you think are the criteria, aspects of a disease that would make it suitable for a whole disease model?
So there are, I'm not going to remember all 5 of them, but there are 5 criteria that Tappenden lays out in the methodological framework paper. But I think the 2 most important are that there is not currently a lot of models that are built in that area. I think if you've got an area, a disease where we already have a lot of work that's being done, there's less value in starting from scratch. And then the other big one is whether or not it is likely that there will be multiple technologies being adopted for that disease within the foreseeable future. Like I said, I'm not going to be able to remember all 5, but they are specifically spelled out. And I think that's a great place to start if one is considering moving towards a whole disease modeling approach. Thanks.
Okay. Great. The next one I've got is from Eldon Spackman. So what's the closest we've come to a whole disease model in I guess in practice in the real world?
I mean, I would get in huge trouble if I didn't say that Paul Tappenden built one. There was a colorectal cancer model, prostate cancer, that was the originator. There are a number of others that are out there. The one that I know the best is a COPD model that was created by Mohsen Sadetsafavi and his team at UBC. There are other models that model a whole disease, but aren't necessarily following the same framework. So they may not qualify as whole disease models, but they do exist. At least two exist in the literature that do explicitly follow that framework. And I'm not up to date on the literature, so there may in fact be more than that currently available.
Okay,
Thank
you. Next question is from David Cameron. What's CADTH's timeline for the implementation of whole disease modeling, and are there any concerns or speed bumps you didn't get to mention in your presentation?
So to David, the first thing I would say is get back to work. Second thing, I don't, like I said at the top, there is no, like my opinion on this is not CADTH's opinion on this. There are so many more things to consider and sort of political considerations, collaborative decisions that are part of the process. And I'm new at CADTH, so all of this work happened before I showed up. Like all of my work happened before I was at CADTH, so I don't actually know. I can't answer that question. I think that there is a new strategic plan that's going to be released this year, and I think we'll find out a bit better once that's publicly available. Thank you, David. Get back to work.
Thanks. And the next question is from Gillian Curry. So what do you see as the barriers and facilitators to moving in this open source and whole disease modeling direction?
The biggest one is just task complexity, that this is a huge undertaking, and there need to be champions with institutional clout and resources behind the move to provide an incentive structure for established researchers, early trainees to take up what is ultimately a very large challenge. I think there is not a huge incentive at the industry level and not a huge incentive at the funder, like research funding level, to be doing this kind of work. And so, you know, a misalignment of incentives means that it's only, you know, crazy people like me who want to learn Python in their time when they're not at work to do health technology management. Like, you shouldn't leave it in our hands. There needs to be institutional support for these approaches. I think that's got to be the biggest barrier, is just that we're not necessarily resolved as a discipline to be moving in this direction. But I think it's coming. I think that shift is happening. Thanks, Julian.
Okay, thank you. The next question, I'll just check the time. We've got time for just a couple more questions. Apologies if not everybody gets their question answered, but
please email me if you want to talk about this.
So this is from Shazad Ganbarian. It is very clear whole disease modeling is the way to go in the future, but the question is, how should we design and standardize the model so everybody can read and adjust the code? And then should we move toward one programming language? I guess focus on the first part of the question, maybe.
Sure. So I want to give another plug for the DARTH working group, the Decision Analysis in R for Technologies in Health. I think what they are the project that they are currently embarked in is setting up standards for coding in R for health economics and for model building and design and construction. And I think it needs to be, like I said, an established group with some institutional support, an interdisciplinary team of experts who say, like, these are best practices. I think ISPOR has a role, but ISPOR is really more on the like design in a broader sense, not design in a very narrow sense of like, how do we structure our code? But I think that there is already sort of a growing consensus, an amalgamation of perspectives towards a common understanding of how to do this. And so I think that same process can be easily shifted to be applied and directed at whole disease modeling. So yeah, I would say that it has to be, you know, a combination of academics and HTA agencies and others. Thank you, Shazad.
And I think this will be our last question from Tanya Conte. Obviously, we'd all like to share models and collaborate, but how do we deal with privacy issues with the data that feeds and runs in the background of the different parts of the clinical pathways? Example, costs, patient data, etc. And I guess particularly, are there privacy issues around patient data? Would be my addendum to that question.
So the model, hi Tanya, thanks for the question. The model that I have, the data set is completely downloadable because all of the inputs are either from the literature or they're the result of outputs from a statistical analysis. So there are no privacy concerns. You can't track someone from a coefficient in a regression analysis. And so finding ways to make the underlying data work is certainly a challenge. If you do need to be using proprietary information, proprietary data sets, once again, the same group that is involved in peer models and that built that COPD model, that group of researchers, that broader team has a service called Prism, and Prism is a model hosting site where you can log into their server, send questions to the model, and get responses without actually interacting with the code or the underlying data. So when we do have those kinds of privacy concerns, that is possible. And again, that is why I think there needs to be this sort of international collaboration between agencies to get around some of these privacy issues so that things can be set up in a way that protects confidentiality, that respects the needs of the various stakeholders, including industry, but that we can have some things, even if we can't have everything public, we can still have some of the underlying code be available for sharing and for modification.
Great, thanks so much, Ian. We're just coming up to 1 o'clock Mountain Time now, so I just think it's probably time to draw to a close. Apologies if we didn't get to your question. Please do reach out to Ian if you'd like to follow up with him. There's some good questions there that we weren't able to ask. I don't know if Nicole can somehow preserve that and share it with Ian maybe.
Yes, I can.
Not overly familiar with this software. Okay, great. So, and then just a quick reminder that if you have any other questions as well, please either email Ian if it's about the presentation or about anything else. You can email noah@ihe.ca. So thank you, Dr. Cromwell, for your seminar today. It was really interesting. Thanks to everyone who's taken part online and who asked questions. And again, apologies if we weren't able to get them answered, but some really great engagement there at the end. And the last thing is the next NOAA rounds will take place on the 17th of February, 2021. And as usual, please visit the NOAA website, noah.ca, to register for that. We can't do a round of applause for you, Ian, but I'm sure if we were, it would be generous, and thanks again.
Thank you all. Thanks very much for your time.